So I will talk about the interrelationships between surgery and the wound healing that is elicited by surgery and the fate of the patient and of the cancer. So why is this topic of interest to me? Well, I am a cancer surgeon. I only operate cancer patients and usually advanced cancer patients with metastasis surgery. And what we see in clinical reality on a daily basis is that patients not always benefit from surgery, and we see that it's a clinical reality that tumor growth and the mechanisms of metastasis can be elicited by the act of surgery. So that's why this is, I think, an interesting topic for all stakeholders involved here present this evening. So first, a little historical overview. It's very interesting to see that in the course of history since ancient times, the value of surgery and what a cancer really is it a foreign object, is it a systemic disease? Those concepts have changed over the past centuries. And maybe you know this picture, it's called Melancholia by the German painter Dürer. And in fact, according to the Greeks, cancer was caused by an excess of black bile. You know black bile, if you have an excess of that, you get melancholy, but you can also get cancer. And the opinion of the Greeks was that you should never touch a cancer growth. And this was based on observations that if skin tumors were treated or cauterized or whatever treatment was possible at that time, it invariably resulted in a recurrence. And patients were not cured and did not benefit and usually died quicker because of the treatment. And you may know that there is still a proverbial saying in our population, and I guess also in the US, that says that if the tumor hits the air, then the fate of the patient is sealed. And that means that if you open the abdomen, then you're certain of a rapid demise. So that's something that's still in the heads of the population as a reality, that you should be very careful with exposing the tumor in patients with advanced cancer. Now, modern surgery was developed based on insights, for instance, by this French surgeon who lived in the end of the 17th and the 18th century, Henri-François Ledran, and he was the first one who really developed the concept of a tumor as a local growth that metastasized in a stepwise fashion from the primary tumor to local regional lymph nodes, specifically in breast cancer. And at that time, the practice of surgical oncology was born, and it was slowly infiltrating in the heads of the surgeons that the more radical you were, the higher the chances of cure and of success, because you removed all the involved nodes and thereby got rid of a disease that was really seen as a kind of a foreign body, just as any foreign body that you can extract during war surgery, for instance, by removing bullets or arrowheads, for instance. And this has then led, in the course of the centuries, to more and more extensive and mutilating surgeries. You see here the classical illustration by Halsted, the radical mastectomy, which removed not only the soft tissue of the breast, but also the muscular layer of the thoracic wall, leaving the patients, of course, with severe aesthetic and functional disabilities. And this has led to some extreme examples. This is a classical paper by Fisher. I will come back to him later, but those are surgeries that are really an extreme consequence of the concept that the more extensive and the more radical that you operate, the better the chances of survival, which of course we now know not to be the reality. And this is an example of a hemicorporectomy. There are about 20 patients having undergone that type of therapy in the world, and I must not remind you, of course, of the fact that there are not only medical and oncological, but also serious ethical obstacles to embarking on that type of procedures. But times have changed, and we now know that cancer is probably, from the start, a systemic disease, and there is a kind of interaction between ecosystems, the tumor ecosystem and the patient's ecosystem. And several models have been described. The Halsted model, that presumes a stepwise spread from the primary tumor to a local regional lymph nodes and then to systemic disease, which is probably still more or less reality in some head and neck tumors and skin tumors. And then on the other end of the spectrum, you have the Fisher model that was popularized by Bernard Fisher. This really states that, for instance, breast cancer is a systemic disease right from the start. So you get, if you look hard enough and with sensitive techniques, you can find cancer cells in the bone marrow, in the blood, in the spleen, starting from very early tumor stages. And of course, in this scenario, you can understand that the therapeutic effects of extensive lymphadenectomies, for instance, or of very extensive mutilating surgery will not be beneficial. This is just an illustration of the fact that we now understand cancer as a systemic disease, and for instance, in the process of metastasis, we now know that what is called a pre-metastatic niche is formed. That means that bone marrow cells and other elements from the circulating serum are recruited, and they will prepare a niche in the target organ, in the liver for instance, that prepare the tissue for the arrival of the metastatic cancer cells. That's quite a recent insight. So knowing that now we have this new insight of the existence of a tumor host communicating ecosystem, and taking into account the fact that more and more patients, in fact, are candidates for metastasis surgery. The systemic treatment got better. We now have more chemotherapy. We have more active chemotherapy. We have biologicals. So patients live longer with metastasis, and more patients are referred for surgery sooner or later. And these elements have led to a renewed interest in this important question: does the act of surgery, or the anesthesia before and after, and the pain relief, the opioids, etc., does this affect the behavior of the cancer in the body and these ecosystems? So I will talk about some experimental data that have looked into this issue, and then I will finish with some clinical studies. Although I must start with or mention right up front that the clinical studies are really equivocal, and that there is no clear hard evidence at this time that this really is a reality. So when we start with the experimental data, there are three groups of experiments that have been done. The first group of experiments has looked at the properties of wound fluid. You know that there are a lot of similarities between wound healing process and tumor growth. In fact, tumors have been called wounds that do not heal by Dvorak. The second group of experiments looks at how the act of surgery stimulates the growth of metastases that are already present, so synchronous metastasis. And the third group of experiments has looked into mechanisms that examine how removal of a primary tumor will affect the fate of the metastasis. So this is the first classical paper published a few years ago that looked at the effects of wound fluid that was transplanted between species. And what they did is that they took wound fluid from injured pigs, just cutaneous wounds. They took the wound fluid and they injected that in mice with a glioma tumor subcutaneously. And what they noticed is that by co-injecting this wound fluid, the tumors got significantly larger, as you can see here. And at the same time, they could determine that the effects were mainly mediated by two molecules in this wound fluid, namely PDGF and EGF, so the platelet-derived growth factor and the epithelial growth factor, and they could prove that by co-administering antibodies to those factors, which abolished, in fact, the effect, namely the DNA synthesis or the mitogenic properties of these glioma cancer cells. So a second group of experiments looked into the mechanisms on how surgery stimulates the growth of a distant tumor. And seminal experiments were performed by the Fisher brothers. Bernard Fisher was a surgeon, is a surgeon. I think he's still alive. His brother was a pathologist who passed away a few years ago. But they were responsible for really a seminal set of experiments that changed the paradigm in how we see cancer and how we see it now as a communicating ecosystem. One of the classical papers of Fisher published in Science in 1959 was the following one. What they did is they injected carcinosarcoma cells in the portal vein of the liver of animals. And then they observed the animals during several months. If they left the animals undisturbed, then nothing happened. No tumors growed in that liver. However, if after 3 months they performed a set of laparotomies, repeat laparotomies, then invariably in all these animals, tumors started to grow in these livers of these mice. And this was, of course, a convincing argument of the fact that the act of surgery or the wound healing stimulus that you elicit by surgery really promotes the growth of malignant tumors. Now, in general, there are, of course, several mechanisms that describe or explain how surgery can affect the growth or the occurrence of metastasis. First of all, mechanical causes, manipulation. It's very well known that if you take venous samples of a colon cancer, for instance, and you would cannulate the venous outflow, you will find tumor cells in there if you manipulate the tumor. That's why the so-called no-touch technique was developed. The same goes for surgery for hepatobiliary malignancies. If you cut the bile duct, for instance, in a bile duct cancer or in a cholangiocarcinoma, we know that we can find tumor cells in there. Anesthesia is, of course, important. I know and I'm convinced that there are a number of anesthesiologists in the room, and we know that, for instance, the opioids have a bad reputation. They are supposed to suppress the immune system and could therefore lead to a compromised oncological outcome. For propofol, the reverse seems to be true. And also the type of anesthesia, epidural, local regional versus general anesthesia, seems to play a role. But that being said, there are, as far as I know, no convincing clinical data at this time, although a number of studies are currently running. Adrenergic signaling and the presence of stress, be it emotional or physical stress, by adrenaline and all the targets of that molecule have been implied as a mechanism that could stimulate growth of metastasis. Surgery can change, strangely enough, the ultrastructure of the target organ, of the liver, for instance, and the architecture of the sinusoids. I will come back to that in a moment. And we also know that surgery can lead to recruitment of bone marrow-derived progenitor cells that can in turn promote the process of metastasis. This is an example of ultrastructural changes that you can see by doing surgery. And this is a group from the Netherlands that was published in Gut in 2011. And what they did is they looked at the integrity of the tight junctions, and it's a specific molecule that they looked into. It's called Claudin 5, and what they noticed is that if you compare both in the human situation and in a rat model, if you compare the liver histology before beginning the surgery versus after the surgery, you see that there is a dramatic downregulation of the expression of Claudin 5. That means that these tight junctions are not really effective anymore, that there's a kind of contraction of these cells, and this exposes the extracellular matrix. And we know that exposure of the matrix is really the first step in the process of metastasis. The same holds true for the mechanism of peritoneal metastasis. We know that inflammation in the peritoneum causes contraction of the mesothelial cells, and this again will lead to exposure of the underlying matrix, and this will facilitate adherence of the cancer cells to the collagen and other types of tissue that you have in that environment. So the third group of experiments looked at the effects of removal of the primary tumor. And this is a classical experiment that was published also years ago in 1958. Also an interesting experiment. I don't know if you could pass that type of protocol via an animal ethical committee anymore, but anyway, what they did was they induced a melanoma tumor that develops metastasis in the lungs, and then they treated the animals in two possible ways. They either removed the normal leg or they removed the tumor-bearing leg. And what they noticed is if that you remove the normal leg, nothing happens with the lung metastasis. Whereas if you remove the tumor-bearing leg, then strangely enough or strikingly enough, there is a dramatic increase in the number and the weight and the size, etc., of the lung metastasis. So what this suggests is that the primary tumor secretes or produces a substance that delays or slows down or retards the formation or the development of the metastatic component of the disease. So that was the first impetus, and this was really further developed by another famous surgeon, namely Volkmann. Volkmann is very well known for his work in angiogenesis. He was the first one to develop the concept of tumor angiogenesis. He was a pediatric surgeon. And this was his landmark paper in the New England Journal of Medicine in 1971, where he for the first time described this factor that was later called VEGF, so the vascular endothelial growth factor. And then later his group discovered or described for the first time this molecule called angiostatin. Angiostatin is one of the 3 molecules that are now known to be secreted by the primary tumor and that suppress the growth of metastasis. So if you take away the primary tumor, there's no more source of these angiogenesis inhibiting factors, and you get a growth of the metastatic disease. And what they did here in this elegant experiment is see what happens if you remove the primary tumor again in a mouse model of lung cancer. Those animals have the primary tumor present. In those animals, the primary tumor is removed, and you see that there is a dramatic increase in the number of lung metastases. However, if you now take serum or urine from tumor-bearing animals and you co-inject it after you have removed the primary tumor, nothing happens anymore. This means that in the serum or in the urine, or in both in fact, there is some kind of factor that suppresses the growth of the metastasis. So this factor was then analyzed and sequenced, and the amino acid sequence was identified, and they came up with this molecule called angiostatin. So it's one of the angiogenesis, one of a series now of known angiogenesis inhibiting factors. Other ones have been described in experimental settings. I will not go into detail for the sake of time, but another one is endostatin, also described by the same group of Judah Volkmann, and thrombospondin 1. So those are the classical sets of experiments that have been performed. There are another number of interesting papers that have looked at this mechanism that are really unrelated with what I've recently, or what I've just told you, but this is an interesting example. This is a study that it's from a group in Argentina that looked at the effect of 2 isomers of the amino acid tyrosine, and tyrosine seems to inhibit the growth of metastatic tumors, and this was illustrated in this animal model. Again, it's a mouse lung cancer model. This is the lung, where you see a number of metastases which was much lower, and so the number was lower and the size was less of these metastases in the lung if you treat these animals with this isomer of tyrosine. So an interesting finding, but it's not being replicated or being translated into clinical studies as far as I know. Now, we live in the age of next-gen sequencing and of genomic analysis, and this is a study published in the Annals of Surgery a few years ago that looked at what happens with gene expression in metastatic tissue, in a mouse model again of breast cancer, after you remove the primary tumor. And what you see here is the fold change in the expression of a number of genes that code for proteins that are important in metastatic growth, invasion, etc., etc. For instance, this metalloproteinase, tumor necrosis factor, etc., etc. So it's clear that removal of the primary tumor also affects the gene expression of the metastatic disease component. So that concludes this short overview of experimental data. What about the clinical data? Well, there are a number of topics that are regularly mentioned or cited as an example of the potential importance of this mechanism. The first one is the mammography paradox. I will explain that in a moment. The second one is, of course, the timing and indication for chemotherapy, either neoadjuvant or adjuvant. The third one is related to whether or not less invasive surgery, for instance laparoscopic procedures, can, by reducing the wound component and the extent of injury, could that translate into a better cancer survival or outcome? And then there are a number of clinical studies that have looked either at the effect or the importance of postoperative inflammation and outcome. We know that patients who develop an anastomotic leak, for instance, after rectal cancer surgery, they have a significantly worse cancer outcome. And so a number of studies have looked into that. And then finally, there are a number of studies specifically from the Netherlands that have looked specifically in human subjects at what happens on the histological level and on the functional level with colorectal metastasis as soon as you remove the primary colon cancer. So I will briefly touch into these topics. This is what is called the mammography paradox. You know that a mammography is really advisable for women starting at the age of 50. That's the consensus in Europe, as far as I know. But there are countries where it started sooner, starting with the age of 40. And what was noticed in this paper, well, it's mentioned in this paper, the original publication was not by Retzky, but it's the same Retzky that was mentioned by you. And what they noticed is that in young women, in contrast to the older age group, there is an excessive mortality in the screened group. So if you screen these women, their survival is actually worse. You see here the hazard ratio. So what is the explanation for this, or a possible explanation for this? It is that young women tend to have more aggressive tumors, tend to have more disseminated, microscopic disseminated disease, and if you operate on these patients, you will stimulate the growth of later metastasis. And that is cited as the explanation of this mammography paradox. So the observation that there is an excessive mortality and the disadvantage of mammography in younger women between 40 and 49 years of age. A second important topic is adjuvant chemotherapy, and there are a number of studies. You know that after colon cancer resection, for instance, it's advisable to start chemotherapy as soon as possible, ideally within 4 weeks, usually within 6 weeks, but sometimes it's delayed. And a lot of studies have looked into what happens if you delay the adjuvant chemotherapy. And this is an example of an individual trial that looked at survival in patients who got delayed chemotherapy after 3 months versus before 3 months after the operation. And you see that there was a significant detriment in overall survival if you have to delay the chemotherapy. A number of similar trials have been performed, and these were combined in this meta-analysis published in the JAMA in 2011 that clearly showed, you see here the regression line of the meta-analysis, that there is clear relationship between the waiting time for starting adjuvant chemotherapy after the procedure and the hazard for death. So that suggests that chemotherapy could be effective in eradicating microscopic metastatic disease. But that's one part of the story. On the other hand, we know from a number of large trials that, for instance, if you give bevacizumab as a part of the adjuvant treatment, combined with FOLFOX or FOLFIRI, either in stage 2 or in stage 3, this study was only in stage 3 patients, colorectal cancer patients, that really did not have or not show the potential that was assumed to be associated with bevacizumab. So that was really a disappointment, first of all for Roche, of course, because that's a huge market that was now closed for them. But anyway, it's puzzling to see that bevacizumab, which is supposed to suppress one of the main wound healing associated molecules, namely VEGF, that this does not really result in an improved outcome for these patients. A third clinical topic is whether or not minimally invasive surgery, could that translate into less tissue injury and thereby in better survival outcome? Well, there are a number of studies that have looked into that. First of all, we know that in laparoscopic surgery, there's also, if you look at the serum, a significant increase in the number of cytokines. This shows you a VEGF, but the same holds for a number of other cytokines examined by this author from the US. And you see that if you look at the level of cytokines in the blood pre-op versus day 5 or day 7 to 13, those are at every time point different sets of patients. They did not do the analysis in the same patient every time. That there is a significant increase in circulating VEGF, for instance, but also other cytokines. And importantly, if you take serum from these patients and you subject it to what is called an angiogenesis assay, like in this illustrated in this table, you see that if you compare the serum from preoperative situation to serum that is taken between postoperative day 7 to 13, that there is a significant increase in a number of these endothelial cell angiogenesis assays, parameters, for instance, invasion, migration, and branch points. So what about the studies that have compared open surgery versus minimally invasive surgery, and then looking specifically at what happens with the cytokines in the blood and in drain fluid, for instance? Well, it's not completely clear. There are varying results, sometimes contradicting results. This is a study published 2 years ago in PLOS ONE, and you see here that they studied a whole range of cytokines. All these cytokines were tested in the plasma and in drain fluids. And what they noticed is that if you look at the difference between open surgery, this line, and laparoscopic surgery, that there's only a significant difference in interleukin 6 and 8. All the other ones, there was not any difference that could be detected. And in drain fluid, the cytokine levels were first of all much higher, were significantly higher, and there was no difference at all between the open and the laparoscopic group. So that's quite puzzling, in fact, because you would expect that if you do a minimally invasive procedure and a much reduced wound bed and tissue trauma, then in the drain fluid you would have less cytokines, but that does not seem to be the case, at least not in this study. This is another study from 3 years ago that confirms this observation, that if you look at open surgery versus laparoscopic surgery in colon cancer, that there is really no difference in the expression of cytokines. You see here interleukins 6, 8, and 10, and tumor necrosis factor alpha were really similar between open and the laparoscopic group. So what about the clinical studies that have been done that randomized patients to either open or laparoscopic surgery? If really doing a laparoscopic procedure would benefit the distant metastasis-free survival, that would be visible or traceable in the studies that have been done? Well, the answer is there is no effect, there is no difference, there's absolutely zero effect of laparoscopic surgery on survival. You see this, this is a result of one of the large trials that was performed in the United Kingdom. It's called the CLASSIC trial, open versus laparoscopic surgery, and this is overall survival. There's absolutely no statistical significant difference in outcome whatsoever. If you combine these studies, then there seems to be a trend towards improved overall survival in patients that underwent the laparoscopic procedure, but you will notice that these estimations are not very accurate. Those are small studies with a wide confidence interval, so it's not the answer is out there, let's say. It's possible that there is survival benefit associated with laparoscopic colon cancer surgery, but there is no formal proof. So the next topic is, does postoperative infection and inflammation, for instance, induced by anastomotic leaks, does that affect survival? And if yes, is that caused by a stimulation of metastatic growth or dissemination by the mediators of that inflammation? And the answer to the first question is yes, it's clear. This is a meta-analysis of a range of studies that has investigated that issue. There is a reduced probability of survival if you have an anastomotic leakage. However, it is clear, all those studies are retrospective, of course, in nature, and it's clear that there's an enormous bias by the fact that you will have more anastomotic leakage in low anastomosis and in larger tumors who already have a worse survival. So this is a very important confounder that probably confounds this finding, and it's really not possible to tell whether or not this is really related to effects of inflammation on metastatic growth per se. this is in continuing on the same topic, an in vitro study that looked at possible mechanisms that relate postoperative inflammation to the growth and the existence of metastasis. And what they did is look at the role of LPS, bacterial lipopolysaccharides. If you administer that to a culture of colon cancer cells, you will see a dramatic increase in the adhesive behavior of these cells. That's something that can be tested in vitro, adhesion, and that's of course an important property of cancer cells in the process of metastasis. If you, however, give a NOx inhibitor or a PI3K inhibitor, then this effect is abolished. So the message of this paper was that inflammation, bacterial inflammation and bacterial products can lead to an increased adhesion of colon cancer cells through these toll-like receptor 4 signaling and upregulation of NOx and other pathways that are involved in the creation of superoxides and of oxidative stress in general. So this is the last slide, or the last two slides, about clinical effects that have been found in patients, and that's already a few years old. It's a very interesting set of papers published by the same group from the Netherlands, if I remember well, from Nijmegen. And what they did is, in patients with colorectal metastasis, they looked at the level of apoptosis, the apoptotic index, in patients with synchronous liver metastasis where the primary tumor was still in place, and patients with synchronous liver metastasis where the primary was removed. And what they noticed very clearly is that there was much more apoptosis in patients where the primary was left in situ. And so this suggests that in patients with colorectal metastasis, synchronous metastasis, it's better to leave the primary in place, because in some way it induces apoptosis in the metastatic disease component. The same group then looked at the metabolic effects of leaving the primary tumor in place or removing it, and those are PET images, and you see here the first scan is before removal of the primary and the second scan is after removal of the primary, and you see here it's not visually, it's not maybe not very clear, but they did a quantitative image analysis and they could demonstrate that the enhancement, so the uptake of the radioactive tracer was really significantly enhanced after removal of the primary tumor. The same mechanism, or the possible effect of removal of a primary tumor on the dynamics of metastasis formation, has been demonstrated in a number of mathematical models, and this is one of those models, but I will not go into detail. So to conclude, what are the clinical implications? Well, there are of course implications for the timing and the administration of adjuvant chemotherapy. In general, we know that in a number of digestive cancers, for instance, perioperative chemotherapy in stomach cancer, for instance, but also in surgery for liver metastasis, improves survival, and that could be related to the mechanisms that have just been reviewed. It's relevant for performing surgery in the presence of microscopic residual disease. A classical example is ovarian cancer. We know that if you perform debulking surgery in stage 3B or C ovarian cancer, then almost all of these patients will recur sooner or later. And they will develop peritoneal metastasis and recurrent peritoneal metastasis sooner or later, even though you performed a visibly complete macroscopic resection. So this means that some way or another surgery can stimulate the regrowth of this peritoneal microscopic residual disease, and I think that's a very important topic of future clinical research. It's also relevant in the determination of treatment strategies, for instance in patients that present with synchronous metastasis in the liver. What will you do? Will you remove the primary first? Will you remove the liver metastasis first and give then chemotherapy and then operate on the primary? So that strategy can also be significantly influenced by the insights into the mechanisms that have just been mentioned. And for instance, the liver first strategy, I don't know if that is being done here in St. Luc. I guess yes, because there are a number of centers now doing that. That means that in patients who present with immediate liver metastasis, you treat the liver metastasis first and then you give chemotherapy, and then you treat the primary. And one of the theoretical arguments is the fact that if you remove the primary first, you could stimulate the growth of the metastatic disease component. And of course, perioperative inflammation. I think the primary impetus for this meeting was a clinical study that is ongoing, where an effort is being done by suppressing perioperative inflammation by non-steroidal anti-inflammatory drugs, and I will not go into detail, but that's of course a major target, a major therapeutic target or preventive target in order to tackle this potential mechanism. There are a number of ongoing trials that look at the effect of removing the primary in patients with stage 4 disease. For instance, in colon cancer, there's a Dutch trial and a German trial where patients with stage 4 disease, with metastasis in the liver, and a primary that is non-symptomatic, that does not need surgery per se, are randomized into either leaving the primary in place or removing the primary tumor. And those trials, of course, will give us important answers, and I hope that they will add to their study a number of translational research subjects or topics that can allow an insight into the reality of the mechanisms that I've just described. And the same type of trials is now being performed in breast cancer. There is a Dutch trial going on, there is in the US a cooperative group trial going on, and then in a number of other countries, similar randomized trials are going on in stage 4 breast cancer. But of course, the answer will probably partly be the development of the identification of novel molecular targets and of novel inhibitors that will address some of these aspects, some of these components of tumor growth that are here illustrated in this diagram, and that were probably addressed by the next speaker. So with that note, I would like to end. I thank you for your kind attention, and if you have any questions, it will be my pleasure to answer them. Thank you.